We would like to welcome Dr. Jennifer Green. Dr. Green is a professor of medicine in the Division of Endocrinology, Metabolism, and Nutrition at Duke University and a faculty member of the Duke Clinical Research Institute. Welcome, Dr. Green.
Thank you for having me.
Of course. And I want to start with, how has our understanding of multimorbidity in patients with and without type 2 diabetes evolved in recent years?
Well, I think there is an increased appreciation for the fact that many people with type 2 diabetes have kidney disease and or heart disease that may be present from a very, very early stage, perhaps at the time that they're diagnosed with type 2 diabetes. And it's also become increasingly clear that if you are a person who has more than one of those conditions, so for example, if you have heart failure and diabetes, your outcomes are expected to be worse or poorer than someone who has just one of those conditions. And we've seen that in study after study. So we need to recognize that risk, and also in particular to recognize the risks that are posed to people who develop these conditions at a young age.
How is this multimorbidity linked to inflammation?
Well, inflammation plays a role in both the development of insulin resistance and type 2 diabetes. And once that condition is present, the chronic state of inflammation that is present clearly increases the risks of cardiovascular and kidney complications. Then those complications in turn increase levels of inflammation. So it's really sort of a vicious cycle that we need to think about and take action to interrupt.
And there's been tremendous progress in addressing cardiovascular and cardiometabolic risk in patients with and without type 2 diabetes, such as, SGLT2s, GLP-1 RAs. And among others. Can you briefly discuss the effects of these medications, including in targeting inflammation and beyond?
Well, I'll spend a good bit of time talking about that in my presentation because it's a fairly complicated topic. However, when we think about the key drivers in particular of kidney disease in people with diabetes, the key drivers are hemodynamic problems, RAS overactivation, and then this huge bucket of things called increased levels of inflammation and pro-fibrotic factors. And so that is an area that, or a process that clearly increases the risk of kidney disease in people with diabetes, as well as cardiovascular diseases. And as you've mentioned, many of these newer classes of medications, the SGLT2 inhibitors, the GLP-1 receptor agonists, and finerenone, a new MRA, clearly improve outcomes in people with diabetes and chronic kidney disease. And we do think that each of those classes of drugs may target and reduce levels of inflammation, albeit through different mechanisms.
Understood. And we now have updated guidelines to reflect how this evidence has changed. But how does the individualization of therapy and patient selection occur in clinical practice? And are these agents typically used in combination?
Well, I'll start with your last question first. Yes, we can and should use these agents in combination because they work through different physiologic pathways to provide a benefit as best we can tell. So I think it is advisable to use combinations of therapy. There are many reasons why care is not modified or accelerated to reduce risk in a fashion that's consistent with current and evolving guidelines. Some of it is a reluctance on both the part of the prescriber, the clinician, and the individual affected by the condition to add more medications. And I would suggest that we turn a critical eye on the medications that patients are already taking and look for opportunities to make substitutions with these newer medications that provide a clear outcomes benefit, maybe for drugs that they're already taking that don't provide that degree of improvement in risk and would be likely to improve either their life expectancy or quality of life or both over time.
Gotcha. And what are some reasons for the relatively slow adoption of these agents outside of endocrinology? And what can be done to address this?
Well, I don't think we should give endocrinologists a pass because endocrinologists aren't particularly good at prescribing these medications to higher risk patients. I would say the proportion of people with diabetes seen in endocrinology clinics is higher when you look at the percentages being prescribed an SGLT2 inhibitor or GLP-1 receptor agonist, but the bulk of people with indications for those medications are cared for in the primary care setting. So this is a primary care issue. Endocrinologists need to improve. Primary care doctors are really the key, I think, to improving the health of populations. And again, I think it does start with education and making sure that there's a clear understanding of the benefits that these new agents can provide. And again, looking for substitutions, opportunities to introduce these medications if possible without increasing the pill or overall medication burden, and just prioritizing drugs that do more than others.
Absolutely. Well, Dr. Green, we want to thank you for your time today. And do you have any other pearls that you would like to add?
I'm not sure if I have any additional pearls I'd like to add, but I would encourage everyone listening to really take a good look at the recent, in particular, ADA KDIGO guidelines to, I think, really help understand what the current guidelines are for the care of people with type 2 diabetes and chronic kidney disease, and really understand how they can easily apply those to their own patients. So it's a really very straightforward graphical representation of what we should all be doing.
Thank you so much, Dr. Green.